Good morning. I'm Miguel Quiñones, and I'm here joined by our Grand Rounds speaker for today, Dr. Nelson Schiller from the University of California in San Francisco, also known as UCSF. It's a great pleasure for me to be interviewing Nelson today because he and I have been friends for over 30 years. So Nelson, welcome to Houston.
Thank you.
Particularly in a day where the Astros won the World Series. And Dr. Schiller's, one of his personal interests is a great fan of baseball. So he knows a lot about baseball, and actually he was rooting for the Astros.
Totally.
It doesn't have anything to do with the fact that you hate the Dodgers, right?
Well, we in San Francisco don't care for the Dodgers. Let's put it that way. So I was delighted to see them lose.
So we have a few minutes for this interview, and one of the things we have a lot of fun doing is talking a little bit with our guests about their careers and what sort of got them into the areas that they're working on. Dr. Schiller and I both share the historical fact that we both got interested in echocardiography at a time when the technology was very, very primitive, and we just could see a few funny-looking waves that eventually evolved to the wonderful technology that we have today. So Nelson, a quick question is, you were a young cardiologist, possibly in your fellowship. What got you hooked into echocardiography?
Well, as I thought about it, since we have been chatting, I remember as a medical student, my professor coming back from the heart meetings and reporting on Harvey Feigenbaum's description of pericardial effusion. And we got a old midliner, Smith Klein, and brought a patient from Roswell Park across the street with a malignant effusion, and tried to replicate what Harvey Feigenbaum had done. Then later on, as a resident, I saw a few examples of ultrasound when Dr. Braunwald had a machine that he was trying out. And then finally, when I came to UCSF, one of the companies left an instrument in the hallway. I took it to clinic and began to realize that about half the diagnoses of patients that we had been looking at was partially or completely incorrect. Aortic stenosis was mitral regurg, VSDs weren't VSDs. Hypertrophic cardiomyopathy was there and unsuspected. And so it was, I was hooked on the technique and opened the lab as a fellow. I was just a first-year fellow, got permission to open the echo lab, and the volume was huge just to begin with, and things built on themselves.
And you saw the technique as something that really enhanced your clinical ability to take care of patients.
Yeah.
But then you had a parallel side of that, which was a research career. An academic research career.
Yes.
I mean, you could just have stayed with the echo as a fun tool to take care of patients, but you took it to another level. And what was your main stimulus to do that?
Well, you know, it just happened naturally. We were in Silicon Valley, and as you know, the story of what won World War II was not the atomic bomb, it was radar. And right on our doorstep was a company called Varian. And they had developed part of the components in radar, delay lines and phased arrays. So we got wind of the fact, this is when Dr. Bill Parmley arrived, we got wind of the fact that they were developing an ultrasound machine based on radar technology, a phased array. So we drove out there and talked them into giving us the prototype. And being in Silicon Valley and then wanting to being with Bill Parmley, who was a spectacular researcher, just got me very interested in a career in research.
Yeah. Now, you've done a lot of things in echocardiography. You've been a person that have described wonderful findings, and particularly in the area of cardiac function. And he gave us a wonderful grand rounds in that topic. But another area that you developed interest over the years was congenital heart disease, yes. Adults with congenital heart disease. And you got interested at a time when there were no real super experts. You sort of kind of like with the echo, you sort of grabbed it and tried to do the best you can. Tell us a little bit about that history.
It was on the job training. What happened, as soon as we opened the echo lab, there were a number of clinicians at our institution that had patients with complex congenital heart disease who are now becoming adults, and they had no idea what the diagnosis was. So they would send them to the echo lab, congenital heart disease, it wrote on the rec. And we would start to do the imaging, and we were totally confused. So instead of going home at 5 o'clock, we were there till 7, 8 at night trying to work these patients out. We put all this effort into going to the literature, looking them up, and so slowly but surely we learned what an Epstein's anomaly was. We learned what a transposition was. We learned all these things, and so we went to so much effort. I said, I'm going to take care of these patients. I mean, nobody else seems to know what they have. And it's been the most gratifying thing, I can tell you. Right now, I can just immediately think of one patient that I met almost at the beginning when she was a teenager, and now she's in her 50s, a school teacher, and having had 3 conduits, Rastelli procedures. I had no idea what that was when I first met her, and making decisions for these people. I like to say that congenital heart disease is real cardiology. Coronary disease is actually peripheral to the heart, and congenital heart disease is real cardiology, and that got me hooked. So about 20% of my practice continues to be these patients with complex congenital disease. As they get to be adults, they have adult problems. They have coronary disease, they have hypertension. Often, to me, hypertension is the #1 disease because if we could eliminate that, we'd get rid of a lot of other things. And to me, if I went to medical school one day and only learned about hypertension, I probably could have snuck by with a pretty good career.
Yeah, and definitely it's worldwide. It's considered the #1 cardiovascular risk. You also started caring for these patients with adult congenital at a time when the surgical repair procedures were barely starting. So actually, you also have seen the whole evolution of those procedures.
Right.
And now, of course, you probably see a lot of adults that were, quote unquote, fixed as a kid, but now they have residual things. So the whole evolution has to have been incredibly fascinating.
It's amazing. I mean, you take things like the Fontan procedure. Every year, the envelope gets pushed a little further, a little further. So instead of being relieved and curing the conditions, we end up with sicker and sicker patients that didn't used to survive at all. So that challenge remains. I mean, as you're questioning me, I'm getting these flashbacks about groups of patients that are so difficult to manage yet so gratifying.
So I hope that some of the audience that sees this interview are young people, residents, and fellows in training. And what would you tell? What do you tell your young residents and fellows who are looking into different career opportunities about the joys and what you need to have if you are interested in academic career, research? I mean, what are the perils that you give them?
And I both agree, imaging isn't going anywhere. Imaging is one of the most important developments in cardiology because it's like the sixth gun in the West. It's the great equalizer, and we now have accurate diagnoses for everybody. Remember, when we were starting out, there were a few gurus that traveled around the country with their stethoscopes, amazing everyone with their erudition. Unfortunately, they weren't always right, but nobody knew that. Who could challenge them? And now we have the luxury of absolutely accurate diagnosis. So I would tell people to go into imaging. I think imaging will never go away. Now maybe one of the projects we're starting is artificial intelligence. I'm waiting to hear about a grant in the next, I hope, week. That I think we need in echo because we've become so complex that we need a checklist. We need to have our images screened before we even look at them. So that's an exciting area that I would recommend for my young colleagues. But imaging, I think you can't go wrong.
I would add a couple of comments to that. Both Dr. Schiller and I are in an age group that a lot of our colleagues and friends are retired. And I think one of the things I sense when I hear you is those of us who have been blessed with an academic career, involved with young people, teaching, exploring ideas, having a lot of curiosity, I think we stay young. You know, you're a young guy. You still are writing grants, you still are passionate about what you're doing. And to me, I think that has been one of the biggest rewards of our careers.
I think
is remaining
it gives
young.
you energy. I don't know about youth. I don't think it can beat decrepitude, but it does give, there's no question, when I get up in the morning, I get into my car, I'm going to drive to work, and by the time I get there, I'm all excited and I feel great. If I were to lay in bed retired, I think I'd probably crumble. So I like to be I'm a geezer, there's no question, but I'd like to be an alpha geezer instead of, or an apex geezer.
And I would just say amen to that. Thank you so much, Nelson, for joining us today.
Well, what a pleasure to be here, Mike, and to continue our friendship. And, you know, let's look forward to the next several decades.
Thank you. I think that's a great one.
Okay.